I would say originally just to know what basically it entails. Most of the patients that we've had, we do not give them any kind of injection to numb. Most of our patients, actually all of our patients, be it on trial or now that we use it as standard of care, we don't use anything to numb. Obviously, you tell them you're going to have a poke, but I kind of go through the process with them as far as the injection, that we clean the area, we're going to inject it, we clean it again, we change gloves, we cover it up, and what they need to do for the care and what to do with their loved ones as well. So they need to be educated. A lot of times the caregiver or the partner is not in the room because they just don't want to see the injection. Therefore, the burden lies on the patient. But because usually you're in a room with them, counseling them before they actually go into the room, then everyone is there for you to go over the care that needs to be taken before, as far as you're going to come in for the injection, and how we clean and what we do, but also what we do at the treatment and also how they need to care afterwards. So that is all gone over with them. It's pretty much the same from start to end of what we do as far as the actual care. Very important depending on the lesion that they have. So if it's something that's visible or palatable, well, you're not going to use the ultrasound. But if it's a nodal involvement, then ultrasound is quite important, and we can use that in order to get exactly what underneath, because you may feel it, but things move, and you would definitely use ultrasound guided in order to help you in that. If it gets on the caregiver or the healthcare professional, obviously you would run it down with water and for 10-15 minutes, but that's pretty much it as far as a spill if it gets onto you. However, if you have a physical spill that gets on the ground or somewhere on some kind of surface, you would use bleach and you would let it sit for about 15 minutes. It could be household bleach, and it's wiped. So you kind of treat it just like most spills that you would have in a pharmacy, in the sense that you would put bleach on it, or that you would clean it, and also something that is vericidal and it would kill a virus. So not all basically Sani wipes are vericidal, so you need to make sure that don't assume that you can just use a wipe. It has to be something that would kill a virus. We cover up the patient with a Tegaderm, so hopefully there's nothing that would ooze. But if it were to fall off before that 1 week period that we like for the dressing to be on, we provide them with another dressing in order to, just in case it falls off for whatever the reason is. And in order to dispose of the original, if there's a gauze that's put on and then over that the Tegaderm, you would put that in a Ziploc bag and dispose of it. But if you're going to go back and put another Tegaderm on yourself, or if a caregiver or loved one is going to do it, they should wear a protective measure. Obviously, you're not going to have, if there's something oozing, it's not going to splash in your eye. However, you should wear gloves and make sure that area is cleaned before and after in order to not have any exposure if there is oozing or anything to that effect, that it would get, the bodily fluid would get somewhere. On average, there's like 1 or 2 patients that only have 1 lesion. So you know exactly, and that's the only lesion they've had, so you just draw up that exact amount and you're done. We have patients who sometimes have like 15 or 20 lesions. The large ones I will prepare like 0.5s, and then going by the bedside, I will just grab a bunch of safety needles and I will change out the needles. The only thing that is very important is that all of this you would have to put in a biohazard container. So I usually have one of those smaller ones, so I can just change out the needles right then and there, and put only the T-VEC right there. So you have the initial treatment that's given to patients. As I said, you have a sheet of paper, or in the EMR, whoever is actually doing the injection would specifically write how many lesions, where the lesions are, the size that they're injecting. And when a patient comes back for their second dose, which is 3 weeks from the initial treatment, if there's new lesions, those are the first to be injected. And it's based on size. So the larger ones are first, going to the smaller ones of the new lesions. And then you would go back, and if all you have if there's new lesions, you get to the new lesions, the largest to the smallest, and then if you still have whatever volume left that you're going to give, or if all of the original lesions are still there, then you hit it again from largest to smallest. So you go to the original ones after you have already injected the new lesions that would come. And after that, patients come in every 2 weeks. So it follows the same trend that you get to the new lesions first. If there's new lesions that come, again, from largest to smallest, and then whatever volume you have left, you go to the lesions that you've already injected. And as the lesions basically go away, then you're not injecting anything. So it could come to a time where and you do this for at least 6 months, but say if after 3 months it's gone, you're not injecting anymore. There's nothing to inject. You don't want to come into contact with immunocompromised patients or pregnant people while you're receiving the TVAC, especially when their dressing is still on and there's possible residual of anything left from the TVAC. Also, healthcare professionals who are immunocompromised or pregnant should not be handling TVAC altogether. So it actually goes to them as well.